So just kind of a brief word about calcium channel antagonists. So there's two classes that we use. The dihydropyridines are more of your peripheral acting, the amlodipine and the cardiopine. They cause vasodilation. And then there's the phenylalkylamines, the verapamil and diltiazem. And we all know that we use the cardizem in the AFib patients to reduce their inotropy and chronotropy. So they're L-type calcium channel blockers, and the amlodipine is at lower doses or therapeutic doses is more selective to the periphery, but in the higher doses, like you kind of lose that selectivity, so you can get more negative chronotropy and inotropy, which is why you see bradycardia, obviously. So some of the pharmacokinetics that are important, especially if you're thinking, is this drug dialyzable? So this is highly protein bound with a large volume of distribution, which are two things that do not go well with dialysis, meaning it goes into your cells and it's bound to protein, so you can't really dialyze it out. So, and the toxic to therapeutic ratio is very small. So you can see toxicity even at what you would consider therapeutic doses. You might have someone who's been on a beta blocker, a calcium channel blocker a while, at the same dose even, and you can still see that they're having toxic effects from it. So this is a chart from the kind of the tox book that they recommend. I bought it because I had book money. So mainly I put this on here for the half-lives. So amlodipine's half-life is 30 to 50 hours. And then they put the primary sites on the far right. The V is for vasodilation, and then the M is for myocardial, like decreased contractility or AV block. So you can see the half-life of amlodipine is quite long. Another thing to keep in mind, some of these preparations like verapamil I know has an extended release. So if someone says they took too much verapamil, that's someone you're probably going to be watching for probably over a day. I think you probably just admit them. I think that would be what poison control or tox would recommend, is to admit someone, even if they look okay. So these are modalities. So the calcium, which we saw they gave, high dose insulin, which I'll talk about, atropine, sure, you could try that and see if it helps. It kind of has a ceiling where you can only give about 4 milligrams in total. So, and I don't know how much it truly helps with these overdoses. And then you can do IV lipid, emulsion, vasopressors, obviously, are going to be your friend for these people. Glucagon, methylene blue, and then the kind of the endpoints for these would be ECMO or cardiac bypass. So how does calcium help? So calcium can reverse the depression of your contractility. It maybe helps a little bit with AV nodal conduction. It really doesn't do much at all for SA node or vasodilation. So it's really not going to help that much in the amlodipine with the kind of the vasodilatory effects. The recommended way to kind of dose the calcium for these is to give about 3 grams up front of calcium gluconate, or 1 to 3 grams of calcium chloride through a central line. And you're kind of titrating the blood pressure, and you're giving that maybe every 10 to 20 minutes. And if you're lucky enough to have ultrasound at bedside and you're thinking maybe that there's a cardiogenic component to the shock, you can look at the heart and see how it's pumping. If it's truly that they have a reduced EF in this setting of this overdose, you definitely want to be giving more calcium. If you think the heart's pumping well and their shock is probably from the peripheral effects, it's probably not going to do that much to give more calcium. And then it says you can safely give up to 10 to 15 grams over the first 2 hours without causing significant calcium toxicity. And the Crit Care Tox guy, I was reading his article about this, says he targets like a 1.5 times normal calcium level. So probably around 14 to 15 on your level. So I'll talk a little bit about high dose insulin. So insulin is especially important in calcium channel blockers overdose because L-type calcium channels exist on the pancreas, and it causes hypoinsulinemia. So you're really correcting that. It helps the cellular carbohydrate metabolism in the heart and helps the heart helps achieve more positive inotropy, helps the contractility. So the kind of the way to dose that is much higher than you would be giving for like your DKA if you're starting them on a drip or something. So you're giving 1 unit per kg as a bolus. That's typically normal insulin with an amp of D50, obviously. And then you're following that with infusion starting. This said the literature said 1 to 10. I think I would be probably starting a little bit lower, probably 0.5, until you can get things kind of at a steady state with how much dextrose you need to add to keep them euglycemic. And then you're checking your glucoses every 10 minutes for the first hour, being very careful with it. So in order to get to a high dose, obviously you have to start low. And you're up titrating by like 0.5 units per kg at a time. Assuming you're maintaining your glucose. So you'll see these people get up to like 10 units per kg per hour. So this guy is 100 kilos. That's a lot of insulin. That's like 1,000 units of insulin per hour that he's getting. He was going through a bag of it like every hour and a half. They just would call up for 3 bags of insulin at a time just to have them ready. So obviously you're thinking you're probably definitely worried about the hypoglycemia, and that's fixable. The real problem you're going to run into is with hypokalemia, and that'll sneak up on you, and it definitely will cause trouble, especially in this bradycardic overdose, where you really don't want to prolong that QT interval because their QTC will get out of whack fast. So one of the tox crit care guys had talked like they're not excited about starting high dose insulin if there's any worry at all with the QTC. If they're checking it and it's like approaching 500. They're really hesitant to start it because there's a high risk of sending them to torsades. And it really wouldn't be a tox lecture if I didn't talk a little bit about torsades. So I kind of added that in there, even though that was not a problem for him. So we give the magnesium, obviously. We know it suppresses the early after depolarization in the cardiac myocytes. And then I was reading about recurrent torsades and what to do, especially in these tox cases. So your goal really is to speed up the heart if they're bradycardic, and that's going to help with your lower your QTC. So they, my thought was it was preventing like a reentrant tachycardia, but I know in most torsades it's typically like a bifocal ventral tachycardia from 2 spots in the ventricles. That's why it kind of looks like twisty and different morphology, the polymorphology. But yeah, so they talked about either using chemicals or electricity. The medication they were talking about was isoproterenol, which I've never used before, but they talked more about the pacing, so transvenous or transcutaneous approaches. The transvenous is preferred mainly because you can get a better capture rate and you can perform without having to sedate them. And usually a rate of about 90 to 110 is sufficient, but you might need to go as high as 140. And then once you achieve capture, you can titrate down after that and to see where they're kind of they're living at. So and then isoproterenol, just in case you were curious, they said start at 5 mics per minute. 0.1 mics per kg per minute in children, and titrate to 30 beats above their natural rate. That's per age, and then stopping QT prolonging medications. So it's more for once they're admitted. So a word about the lipids. So giving lipids kind of came up for a lot of overdoses we saw. So we know that it's indicated for the cardiotoxicity from like the local anesthetics if people have a lidocaine overdose. And then there's mixed results for other fat-soluble drugs, but they basically say use it as an adjunct. If someone is shocky and they had a toxic ingestion, that maybe what they took might be fat-soluble. So I think they usually have a low threshold for trying that if someone is, on death's door. And then a word about vasopressors. So you saw that we used epi kind of off the bat. And your choice of vasopressor in the ER might depend on what exactly they took and what you think their body is doing. So for amlodipine, I think norepi is a solid choice because it has higher alpha, but also gives you some beta 1. And then epi, has more beta 1 compared to alpha 1, but, basically acts on everything. So if you think their shock is more cardiogenic, maybe try epi. And then this is more basically about high-dose insulin as your first-line pressor. So I got this from the Tox and the Hound website. They're toxicologists, and they work a lot in critical care. And they were talking about these studies they were doing on animal models with isolated propranolol, so beta blocker overdose. And they said that the vasopressors can actually have a worse effect over time than placebo. And the high dose insulin was really what they were preferring to use in this specific scenario. And this is specific to calcium channel blocker, beta blocker overdose, not like just undifferentiated shock. This is what is going on. So that is what they were kind of shooting for, is definitely using high dose insulin as to help with the cardiac contractility. And then they had, did I say that? Yeah, they had some caveats to this. They said that when they were using pressors, they weren't using high doses, and the power of the study was very low due to ethical and logistic dilemmas given their animal study. So there's definitely some caveats, but they followed up that first study with this second pig study where they used vasopressors with high dose insulin and compared it to each alone. And they said that they did better with a combination. So it kind of makes sense in my mind if it's going to help kind of boost the contractility of the heart. So they said the way they looked at it over time, and this time period is over days, is that the adrenergics that they gave, the epi or the norepi, kind of converts the heart into like a drag racer, ready to go, working fast quickly. But the insulin is slow to start and pull the load for the long haul, more like a diesel engine. So here's more of his course. So he gets up to the ICU about 3 p.m. on day 1. The progress note from the ICU at 7 p.m. that he has escalating pressure requirements, lactic's going up, his extremities are cool, although the wrists and ankles are warm. He's on norepi and epi now at high doses. His systolic is still in the 70s with MAPS in the 50s. He gets a bolus of methylene blue and started on high dose euglycemic insulin therapy at that time, and they added angiotensin II. They discussed it with the ECMO team. The ECMO team is at Butterworth, so they just decided to transfer him to Butterworth just so they have that as a backup. And then he has more hypoxemia, probably because he got 4 liters of fluid, so they switched him from D5 to D10 to concentrate it further. And then in the high-dose insulin article I read, they actually said they can use D50 as their euglycemic agent, and even sometimes D70 to really concentrate it so they're not getting fluid overloaded. I didn't really mention about methylene blue. So methylene blue works in the periphery. It stops the conversion to nitric oxide so that you prevent vasodilation. So that specifically would probably help in amlodipine to help with the vasodilation on that smooth muscle wall. So they did give that, and then I'll talk about angiotensin II in a second here. So who should get angiotensin II? This medication I don't have much familiarity with. I don't think I saw it on my ICU rotations at Saints or at Mercy. I think it only became available in the US around 2017. Obviously they have it at Butterworth and Blodgett because they were using it. And then I read this article from Toxin. No, actually this one I think was from EM Crit. Where they talked to this guy, Ronaldo Bellomo, which I think is an Italian critical care doctor. And he wrote this article about basically using renin as like a marker for who to give angiotensin II to. They said septic patients who need renal replacement therapy are kind of bound to need it, or anyone who was on ACE inhibitors prior to their shock state would benefit from it. And then he found like a renin level where he thought was kind of a good indicator for starting it as a peripheral vasopressor. So if you're as far out from step 1 as I am, and we all are, the RAS system could probably use a little bit refresher. I'm not going to go through the whole thing, but the endpoint here, you can see plus arterial vasoconstriction, increased blood pressure. So you take angiotensin and tensinogen from the liver, convert it to angiotensin 1 based on basically a low perfusion state in your kidneys. And then your kidneys produce renin, which help convert that. So if you have high renin levels, meaning your kidneys are saying, we're not perfusing well, then he said, give angiotensin 2, which is naturally occurs in your body, but you're basically boosting it. Similar to like how you use vasopressin to kind of work on the receptors that would typically respond to it. So that's kind of like the simple of why they give it. It just helps peripheral vasoconstriction. Someone say Mars? So basically it's like liver dialysis. It's extracorporeal liver replacement device. It's MARS stands for molecular absorbent recirculating system. And it's more studied in like acute liver failure. It's kind of liver failure, but I think the theory is that this is protein bound, and maybe if you're kind of liver dialyzing that you can replace the albumin bound xenobiotic drug with like regular albumin. I don't know. I'm not quite sure. There wasn't a whole lot on up to date. This is the extent of how much info there wasn't up to date. All of this. There wasn't a whole article about MARS. But yeah, calcium channel blockers are the real deal. They should not be taken lightly, basically in any amount.